Hi there, my name is Sarah Costello and I'm presenting asthma in the school-age child. The case study involves Dominique, who is an 8-year-old female. That is what we have for her demographics. The history of presenting illness involves her asthma symptoms that she's been experiencing for 1 year. Objective data that was provided is that the peak flow often is about 80% of predicted, and the patient uses albuterol rescue inhaler 2 to 3 times a day, almost every single day. The health assessment of the exam when the patient comes in would definitely involve getting a lot of history taking from the patient herself and the family member who's present with them. We are going based off the expert panel report from 2007, so EPR3 guidelines, which reviews a process that the patient would be going through when they come in. So it involves the assessment and monitoring, predicting the exacerbations, usefulness of the peak flow, discussing what precipitating factors lead to those exacerbations, and of course determining lung function. So with their recorded measurements, as well as maybe taking a new one at the visit. We want to, talk about severity and frequency of the symptoms, nighttime awakenings, use of the short-acting beta agonists, interactions with normal activities. So we're asking questions like, how was your day at school? What symptoms do you have after you've been walking through the halls or going into different classrooms? Is it worse during the morning or after school? Is it worse when you're doing physical activity? We really want to get a good history of the presenting illness and determine, from subjective data what the disease is looking like day to day. So the EPR3 does have classifying asthma severity table, and this is for children 5 to 11 years old, so that does fall into our age of our patient. Classifying this is dependent on whether the symptoms are intermittent or persistent, and we going through each one of these symptoms, nighttime awakenings, use of the rescue inhaler, and overall lung function, we can place the patient within a moderate persistent severity or moderate persistent asthma. Because she's been experiencing daily symptoms and use of albuterol 2 to 3 times a day. We don't quite know more about the limitation in activity, but we would ask about that. We would also ask about how many nighttime awakenings, and we know that the FEV is 80%. So all of this falls within the moderate impairment. And so that classifies her under that category. Then we can go on to recommend this step for initiating therapy. She would fall under step 3. So now we're looking at wanting to use a daily medication for her rather than just using something to treat as needed symptoms. So now looking at the stepwise approach for managing asthma, we're looking at this a little bit more closely as step 3 is what corresponds to the patient's diagnosis. This examines the need for daily medication. If the patient is currently in step 3 with uncontrolled, persistent, moderate severity asthma, we would want to prescribe her with a low dose inhaled corticosteroid with the combination of either a LABA, so the LABA is the long-acting beta-2 agonist that's used in combination, never prescribed alone, or you would start the patient on a medium dose inhaled corticosteroid. Because of the different possibilities and treatment options within this step 3, it's important to consider the patient characteristics, what that history looks like for her presenting illness, and what the risks may be versus the benefits. Additionally, with considering each step and what might be more useful to the patient, we're talking with the family how the patient would be able to, adhere to the medication regimen. So before talking more about inhaled corticosteroids and the step 3 treatment approach, I want to talk about the pathophysiology behind asthma. I believe it's really important to be able to consider what the treatment goal is. So any anti-inflammatory drugs that we're prescribing, we're hoping to stop or reverse the airway hyperresponsiveness, preventing symptoms and obstruction. So the goal is to prevent the airway edema, hyperresponsiveness, bronchoconstriction, and ultimately in some patients, airway remodeling, which is usually unlikely seen in children, and especially after they've only been having asthma symptoms for 1 year, but that is what we're looking at. So we're kind of stopping the process of, we have this inflammation which causes the back and forth between hyperresponsiveness and obstruction, which then causes those clinical symptoms. So looking at what the table shows, the interplay and the interaction between the airway inflammation, then we can better determine what we're trying to prescribe to intervene in this cycle. So why are inhaled corticosteroids the preferred treatment approach? And it's based on their broad mechanism of action that provides treatment to that interplay of inflammation that we just reviewed above. So the National Heart, Lung, Blood Institute that provides the expert panel concludes that the inhaled corticosteroids are both potent and consistently effective in the long-term treatment. The pharmacodynamics, which we'll review in the next slide, account for why it is the best preventative therapy. However, what we're concerned about is whether the patient will be sensitive to it or not, and that varies patient to patient. So we do have to remember that the sensitivity decreases with smokers, people with asthma with the neutrophilic inflammation, African Americans with poor asthma control, all of which really doesn't apply to our patient, but it is good to consider before prescribing. So the preferred approach is to start the patient on a low dose inhaled corticosteroid, see how the patient responds. If the asthma persists, increase the dose, and if it continues to persist, then add that additional LABA. So I think it's important to consider the table and the stepwise approach in this. It's not you can go back and forth, you can add, you can decrease, but it's always good to see how the patient best responds to the inhaled corticosteroid. So this is the mechanism of action, how the corticosteroid works within your body. It affects the inflammatory cells and structural cells. So with the inflammatory cells, we're looking at a decrease in number of those cells to work at preventing the inflammatory process. And it also works on the structural components, so the smooth airway muscle, the endothelial cells, and the mucus glands. So it decreases secretion and the constriction as well. So definitely quite a bit of things going on with the corticosteroids. It would probably take an entire presentation to review that, but it's good to look at how broad the spectrum actually is. So here we have the pharmacodynamics of the inhaled corticosteroid. So it's important to consider where this is being absorbed when it goes into the body and what the potential side effects of it are pertaining to the system. So some of it is deposited in the lungs, 10 to 50%, and then within the lungs that works on the inflammatory cells and structural cells. And then some can enter into systemic circulation. That's where we see those side effects we'll talk about in later slides. The other portion of the medication is swallowed, and that's 50 to 90%, goes through the GI tract and then is absorbed from the gut and processed in the liver. So these are all things to consider when prescribing the medication. If the patient has any liver abnormalities, if the patient is on any medications that would affect the absorption of medications within the liver or the gut, all just things to think about when we're considering how the medication will actually work within the body. Based on the guidelines that I have been reviewing from the National Heart, Lung, Blood Institute, it looks like most of the benefits are achieved with the low dose inhaled corticosteroid for mild to moderate asthma. We would not prescribe that to someone with severe asthma. But the two most common medications I found from the American Academy of Family Physicians are the beclomethasone and then the Pulmicort. The Pulmicort is what has been used in most studies to determine safety, side effects, and adverse effects. So that's the Pulmicort dry powder inhaler, and it is safe for ages 6 to 11. So the adverse effects that we see most often are local, and that's the oral thrush, especially when you're not rinsing after using the inhaler. But it's more common with a higher dose inhaled corticosteroid, and if we are going to prescribe a low dose, it's something to educate the family on and the patient on, but it's not going to be as big of a risk factor. Dysphonia, we sometimes see vocal stress, but that's again most common when you're increasing the dose. Reflex cough, bronchospasm, that's if you are inhaling it too fast. So this is again where these side effects are important to educate the patient on, and educate them on slowing the rate of inspiration to prevent the bronchospasm. Systemic effects are again seen when the medication is introduced into systemic circulation, and that's when we're looking at changes to growth and development, bone mineral density, glucose metabolism, those three big ones. The growth and development we are particularly concerned about in children, but current data suggests that inhaled corticosteroids may decrease the growth velocity. However, the effects are very small, non-progressive, and they are reversible. So these studies used the Pulmicort. So if the family wanted to know about that, we can say Pulmicort, which is one of the most common inhaled corticosteroids, was studied and did demonstrate a very low risk of changes to growth and development. Bone mineral density did not show to have any serious effects on children, so that's good to know. Glucose metabolism in children, the inhaled corticosteroids dosing matters, so it looks like it did not affect fasting glucose or hemoglobin. However, if the dose was high at 1,000, it did raise the fasting serum insulin levels, but interestingly enough, didn't change the glucose tolerance test. That remained within normal limits. So these are just things to monitor the patient for during their follow-up visits, see if they have any changes in glucose. So what we have been discussing is mainly the medication therapies for treatment of asthma, but of course treatment continues much beyond that. So after obtaining an appropriate health assessment, both the subjective and objective data, and determining the patient's severity, frequency, and risk factors, it is next important to make sure they have the appropriate education on the mechanism of action, the pathophysiology, the side effects, the risk factors, and adverse effects of the medication we'd be prescribing, as well as how to maintain appropriate adherence to the medication, how to inhale the full dose, and how to maintain the appropriate hygiene afterwards too. We also want to discuss how to control the factors that are affecting asthma, such as allergens. We think about dust mites, animal dander, mold, anything that may change the air quality, pollen. So we want to discuss maybe what those allergens are and try to limit them. So we can educate the patient on maybe being careful on working outside in the playground, or going through a sandbox, or whatever it may be that the child is doing at the time. Staying inside when pollen is high, that's something we definitely want to talk with the parents about. Keeping the kitchen and bathroom clean and dry to prevent mold. And then, of course, we want to manage the exacerbations. So we want to talk about how effective is the albuterol, or when are you using it, and preventing those is most important. The alternative therapies, which I'll discuss in the next slide, we would consider non-pharm therapies or herbal supplements as alternatives. But of course, the inhaled corticosteroid is the most important treatment option. So for medications, the cromolyn and netocromil are included within the new guidelines. However, it's still not the preferred treatment for mild asthma. They can be used as preventative treatment, so using it before exercise or before you're going to be exposed to those allergens, but it's not for treatment. So the similar anti-inflammatory actions are not as broad. They do not help when the patient is actually experiencing the bronchoconstriction, airway inflammation. It's really used as preventative. Non-pharmacotherapies would be reducing the environmental exposure to cold air, humidity, pet dander, dust, really having a conversation about their environment, their living situation, and talking about how to reduce the allergens. Complementary therapies, I definitely saw that honey in tea or just having a spoonful of honey can reduce inflammation, and ginger and garlic have worked as well. It's definitely not something the patient should be using as a monotherapy, but if someone wants some alternative options, it's a good idea to suggest those. Now, looking back at the stepwise approach to persistent asthma, we have to remember that treatment is ongoing. It does not just stop at one step and the patient is good for the next several years. We have to keep thinking about the patient being happy in the treatment therapy they're in, or whether they should be taken a step down or a step up, or if we need to continue within, say, step 3, but add a different medication for combination therapy. We're continuously evaluating how the asthma is controlled. If it's well controlled over a 3-month period, we might not need to change any treatment, but we'd still monitor the patient. And when considering if a patient should go up a step or down a step, that is where there's a whole new set of education materials we'd be talking about to maintain medication adherence, and make sure that the patient knows what the new risk factors are, and if we're taking the patient a step down and off a medication, making sure they again remember what those warning signs are of an asthma attack, educating them on coughing, wheezing, difficulty breathing, or even the less obvious early signs that you can get, which is the itchy chin, waking up at night, headache, thirst, mood changes. I think with each visit and each change in therapy, we have to re-educate the patient and so the child and the parent on these symptoms, because it can be so easily forgotten, and we definitely want to prevent any exacerbations. Because each medication, each inhaled corticosteroid comes with its own risks and benefits, I wanted to look specifically at Pulmicort, one of the most common inhaled corticosteroids, especially for children. So this is a once daily treatment for maintenance of asthma. It's recommended that we start the dose at 200 micrograms to take twice daily. Very important to educate the patient that this is a regular interval medication and that's how it's best used, is around the same time of day, twice daily, trying not to forget dosing. It is not used as a bronchodilator, so it's not a rescue inhaler. We do not use it once we are experiencing those acute symptoms. So that's also important to educate the patient and family on. Proper inhalation administration technique should be demonstrated within the visit because it's not effective if the patient is not inhaling correctly, and we want to make sure they're getting the full dose. Also good to talk about the side effects, respiratory infection, pharyngitis, sinusitis, voice alteration, some of which we already discussed, but I will say when reviewing studies on the pulmonary effects, it looks like it's a very low risk for pulmonary respiratory infection. What we most commonly see is those local effects of oral thrush and sometimes some GI symptoms, but it definitely has very low adverse effects. So that's good. Drug interactions, medications that are used in combination with this to treat asthma have not resulted in an increase in adverse effects. But patients that are on systemic corticosteroids, such as prednisone, are very susceptible to an increase in adrenal insufficiency when exposed to trauma, surgery, infection. So that's where we see those patients that are really immunocompromised when they're on both. Those medications. Mechanism of action, also important to educate the family on and patient on. It is an anti-inflammatory. It exhibits corticoid activity and affects multiple cell types and mediators such as histamine that are involved in allergic and non-allergic inflammation. So overall, it looks like we are determining safety, what is going to be most effective for the patient, and the inhaled corticosteroid is definitely the most effective treatment. Safest to start on a lower dose initially and see how they adhere to it, see how it's worked in controlling asthma symptoms, and go from there. And like I said, education is just huge during this whole process. And at each visit during any changes to the therapy, we want to re-educate them on those warning signs, risk factors, and what we may see for side effects. So that concludes the presentation. The child, Dominique, 8-year-old female, would definitely require a follow-up visit after prescription of inhaled corticosteroid. We would also want to make sure that the family has the effective resources needed to provide this treatment and have a full understanding on what the diagnosis entails. So we would want to arrange a follow-up visit within 2 to 6 weeks. I think probably 2 weeks or on the earlier side is the best, so we can just see how they're working with it.